open for discussion, and still we have our respectable chairman and Dr. Mohamed Fawzi as well, and I would like him to take the chance to thank him to let me the chance to be the moderator of the prostate session. And now it's open for questions, and still Professor Giganti is with us, and for any question from the audience or anyone. Okay.
Thank you, Dr. Manal, for moderating this different session, because this session has a unique topic, which is the prostate, and the prostate is always a unique topic. I have a simple point of discussion with my dear friend and longtime brother, Dr. Hani. Now we're in Egypt. We're starting a national program on early detection of prostate cancer. Okay, so the idea now, as we all know, nobody usually dies from prostate cancer. Nobody usually dies from prostate cancer. It's not a common cause of mortality, but it's usually diagnosed a bit late. So where are we from when we have early detection? Where are we from local treatment instead of radical radiotherapy or surgery? I mean by local treatment, either laser or HIFU, the new innovative techniques that have already FDA approval. What's your opinion about this? For local ablation of early detection of prostate cancer in lesions within the capsule of 1 to 1.5 centimeter size.
Thank you, Dr. Mohamed, for your very valuable question. As we all know, prostate cancer is a very slowly progressive disease, and actually the current treatment modalities have transformed prostate cancer into a rather chronic disease that you can live with. And many of the patients of prostate cancer, even the ones who are discovered on metastatic prostate cancer basis, even those patients have a very high potential of a lifelong life expectancy. So, of course, we have many patients with aggressive disease, and those are the ones that the early detection policies should be directed to, and the patients with positive family history, and these are the patients that are that will benefit most from the early detection policies. I think in most of our hospitals all over the country, the PSA is available within most of the labs. Most of the hospitals now have MRI machines, and there should be more collaboration between the urologists and radiologists and the oncologists to better guide the patients into their treatment modalities. And this will, of course, take place by our continuous education and continuous continuous conferences and meetings like that. That will help for the benefit of all our patients.
Thank you so much, because I think a lot of research needs to be done in this domain, especially when in the small size prostate cancer in the very early phase stage. I think usually and all over the world, still this zone still new, because usually cancer is always larger. So this zone needs a bit of more research. I would like to ask also Dr. Manal Halim a very strategic question. In cases of BPH, in patient complaining of going to the toilet, complaining of prostatic symptoms, currently in 2024 and 2025, should we still stick to TRUS or should we go to MRI? BPH, yes.
Let's ask Dr. Giganti for this question. Professor Giganti, please. You can answer Professor Mohamed, because I have a lot of questions for you again.
So the question, if I understand correctly, is about BPH, right? Yeah. So what should we do then? So actually, there are...
Some patients prefer to do an MRI than to do a transplant, actually.
Yeah, exactly, yeah. And I mean...
If the cost is not an issue.
Yeah, if the cost is not an issue, I think we should go for an MRI, basically. So we can have a broader idea of what's going on, actually. And also with embolization, actually, we have seen a lot of patients that are followed up with MRI after embolization. This is what we see in the UK. So if I had to choose that I don't have any restrictions in money, I would go for an MRI. Yeah.
As Professor Jargenti is a professor in MRI, he will choose MRI, of course. Especially you said that it's not costly, so it's no problem for the patients. Yes, Professor Hayni, تفضل. وانا say so, تفضل. Okay, sure. Yes.
From the clinical point of view, as we see, most of the patients prefer to do an MRI than to do a transrectal ultrasound, because if the cost is the same, I'd go for MRI definitely.
Another question for Professor Jargenti about his first lecture. He was talking about the PI-QoL scoring. Professor, how can we improve the quality of our MRIs? I know the PI-QoL scoring. So what to do to improve the quality of MRI, especially if you are using the biparametric as a screening method all over the nation. So we need the quality. What to do? Just give us some advices from your expertise.
Thank you. So the first thing is to acknowledge that there are some issues with the quality, if there are any. So I think the first thing is to look at the images and see if they are compliant with the PARAS guidelines that we have seen. So the technical details, the slice thickness, the presence of a high B-value sequence, fat suppressed images for DCE sequences. So this is the first thing. The other thing I think is really important is to discuss with your local physicist and the vendor of the machine that you are using, because sometimes they have dedicated prostate MR protocols and you might want to look at them and see if you think that the quality is good. And the last thing is to have a metric to evaluate the quality of your scan. And in this case, we have PI-QoL version 2 now. So it's really important that the radiologists, the radiographers, and the physicists know how to apply PI-QoL. PI-QoL version 2 is open access. You can download it, you can read it, and it's relatively easy to use. So I would say the first thing is to look at your images, use the PI-QoL score, check the quality of your scan, let's say the first 20, 30, and then see where you can improve. And also ask your colleagues if you are not sure that you have some doubts. So I think that the most important thing is to look at the images, acknowledge that there is an issue, use the PI-QoL score, and then ask for improvement.
How many times do you recall for your patient if the quality of films are not okay? And is it any kind of preparation that you must do before do the MRI to eliminate the rectal gas or anything? How many times do you recall them? Do you recall the patients or you don't recall?
So it's really difficult to recall the patients because sometimes we are not there on the machine. It's only the radiographer. Especially in the biparametric setting, you don't need to give the contrast, so you don't need a dedicated doctor there. So it's really important that the radiographer knows what to do and to evaluate the quality. For example, if there are artifacts on rectal gas, it's really important that the radiographer knows it and repeat the sequence. The other thing that I think it's really useful is to acquire the diffusion weight imaging at first before the T2. In this way, you don't give the air the time to warm up in the bowel. So there are some studies saying that you should do diffusion first and then T2 to reduce the presence of artifacts on rectal air. So this is something that you might want to consider. And the other question is about the preparation. So according to the PARAS guidelines, you can use, for example, antispasmodic agents, or you can use, for example, buscopan, for example. There is an issue here that if you use it, you need a doctor on the machine. And also there are some studies saying that you could do an enema, but the problem with the enema is that you promote the peristalsis as well. So you might end up having artifacts. I think the most important and the easiest thing is to ask the patient to evacuate just before the MRI.
I have a question to my dear friend, longtime friend, Dr. Mohamed. Mohamed Shakir is a pioneer actually in prostatic artery embolization in Egypt. He's one of the early beginners of this technique. And with the current starting implementation of the local regional treatment, which is through laser or HIFU. And there are people who are working PAE, with people are working local ablation, and people are working both. I'm asking you, where do you see PAE is going? Is it going to maintain, or is it going, both are approved, both are FDA approved, either HIFU, laser, and PAE. Where are we going? Which is, go ahead.
Thank you, Professor. Dear friend, Dr. Mohamed Fawzi, for the invitation, for the organization, for everything. And this is a very interesting situation because I know your interest in HIFU.
Tricky question.
But let's refer to the data and the literature. Till now, BE has the upper hand still as a result, and even we have a long-term outcome for BE now more than 10 years, so it is well established for PPH. HIFU still, I think it needs more data, and maybe we need more comparative studies between the BE and HIFU, or even the echo laser, also with the minimal invasive techniques evolving in the last era. So I think we need more data, but till now, still BE, the upper hand.
Well, actually, I would like to announce that the first, hopefully the first HIFU machine will be coming very soon for prostate, for cancer and BPH, inshallah, and we will start studying, but the echo laser is growing very fast, by the way. So maybe with the research, there is always a place for all techniques, and they're all minimal and non-invasive. But I mean, the progress by time will definitely take the lead. So this is always the question. But of course, PAE has been long time working.
Of course, evolving of many other techniques for BPH. This is options, more options for the patients. Yes. And there are some patients that are not suitable for PE, for example. So I do echo laser. So I do for them echo laser if there is high creat, for example, and or technical issue regarding the prostatic artery embolization, or severe atherosclerosis or something. So of course, these are more options for the patients. Welcome for more options, no problem.
Yes. I would like to make a comment about echo laser. It is still one of the newest minimally invasive techniques for BPH treatment. However, it's not yet a valid treatment option. Until now, there are a lot of clinical trials are still undergoing, and actually we have one trial in Cairo University about the echo laser. Outside Egypt, it can be done by a urologist or an interventional radiologist. However, we are still waiting for the results of these studies because it sounds promising. However, it's not yet a valid treatment option for patients.
This is true because it's still starting in Egypt. This is very true. But the idea is that it came to us after being FDA approved. Definitely it has its patients which cannot be done. So it's all, we do not want to the technique is still fresh, still new.
Yes.
Needs a lot of research, needs collaboration. Urologists do it, IR do it sometimes, surgeons do it even.
Yes, yes.
So the privilege is to whoever can do it to the best interest of the patient, because by the end we give the service, we are patient-centered. So we are really centered about the best interest of the patient. So it doesn't, this is not the real issue, whoever gives to the best to the patient. But the more non and minimal invasive we are, I think this is to the best interest of the patient. But we will see starting collaboration between urologists and interventional radiologists and our vendors also. Companies have to share in this research.
Yes, definitely.
Definitely, yeah. I think we will have the new era for the prostate is growing, especially with the growth of the screening, because when the screening grows, the real challenge will appear in the very small lesions, not in the large lesions. This is the real challenge when we're talking about cancer. So let's see what next year will show us in the next year's conference, inshallah. Thank you, Dr. Manal.
Thank you. And then now I would like to terminate our session, but I would like to remind you all, because we have a workshop at Hall Z.